England, the year 1312. A 24-year-old woman named Margaret is lying flat on a wooden table. The room is cold, made of stone, buried beneath a monastery in London. She did not choose to come here. Her husband brought her, a wool merchant who told the monks that his wife cries too much, refuses to eat, and does not obey him the way a wife should. He wants her fixed. The man standing over her is not a doctor, not in any way we would recognize today. He is a cleric who has read old Greek texts, but he has never actually examined a living woman's body. He does not know what organs she has. He does not know how they work. But he has read something. He has read that the organ responsible for carrying children is not fixed inside the body, that it moves freely, like a living creature wandering through the flesh. And when it travels upward toward the throat, it presses on the lungs. That pressure, according to his books, creates a condition called hysteria, a word taken directly from the Greek name for that organ. So he has a plan. Step 1. Hold foul-smelling substances under her nose to push the organ downward. Apply sweet-smelling herbs to her lower body to pull it back into place. If that fails, step 2. Insert a tube and direct smoke from burning herbs into the most private parts of her body. If that fails, press hard on her abdomen from the outside to manually move the organ. If that fails, drain her blood. If that fails, give her something vile enough to force her body to purge whatever is stopping the organ from settling. Margaret is strapped to the table, not because she is dangerous, because the things being done to her cause the body to move on its own, and that movement gets in the way of the work. Leather straps across her arms, leather straps across her legs, tightened by an assistant whose hands move without hesitation, because he has done this many times before. Margaret stares at the ceiling. The stone above her is damp. The room smells of smoke and something sharp she cannot name. The man preparing his instruments above her looks calm, focused, certain. He genuinely believes he is helping her. What was about to happen to Margaret was not a crime. It was not malpractice. It was medicine, the standard, accepted, official medicine of the Western world. These assumptions did not die in the Middle Ages. Some of them are still alive today, documented, measurable, real, in the gap between how seriously doctors take a man's pain versus a woman's pain. The stone room where Margaret lies strapped to that table is not as far away as you think. Stay until the very end, because the line connecting what was done to her and what continues to happen will change how you see the history of medicine forever. The central problem that drove all of this was simple. Men controlled the medical treatment of women's bodies while knowing almost nothing about them. And the systems that kept them ignorant were the very same systems that kept them in power. The medieval church banned the dissection of human bodies for most of this period. By the 13th century, some Italian universities had begun performing limited dissections, but those dissections were performed almost entirely on male bodies. The female body remained largely unopened, unstudied, unknown from the inside. The physicians treating women were not working from observation. They were working from texts. Galen, Hippocrates, Aristotle. Men who had written centuries earlier. Men who had never opened a woman's body to look inside. Men whose ideas about female anatomy were guesses built on one assumption, that women were simply incomplete men. Those texts taught that the organ responsible for carrying children was not fixed in place, that it wandered through the body on its own, like an animal trapped inside a larger animal, moving up or down in response to things physicians could manipulate. This theory, which started with Hippocrates, was expanded by Galen and then adopted without question by medieval physicians, became the foundation of women's medicine for over 1,000 years. It was never tested, never verified, never challenged through actual examination, because the people who could challenge it, the women living inside the bodies being described, were shut out of every single place where medical knowledge was created and passed on. Women were barred from universities, barred from medical schools. They could not study the very texts that claimed to explain their own bodies. They could not legally practice medicine in most of medieval Europe. This exclusion was enforced by law and by the church, which treated female involvement in medicine as a violation of the natural order, the same order that placed men in authority over women's bodies, just as it placed men in authority over women's souls. A woman who treated another woman's illness was not practicing medicine. She was trespassing on male territory. The consequences ranged from fines to imprisonment, and in later centuries, to accusations of witchcraft that could end at the stake. So the people who actually experienced these conditions were banned from studying them. The only people permitted to treat women's bodies were people who had never lived in one, never felt what women felt, and whose entire understanding of the female body came from texts written by other men who had also never looked inside one. What this created was a closed loop. The text said the female body worked a certain way. Physicians treated women according to those texts. When the treatments failed, and they always failed, the failure was blamed on the woman's body, never on the physician's understanding. The texts were never wrong. The woman was always the problem. And since no woman could challenge the texts, study them, or practice the medicine being practiced on her, that loop ran unbroken for 1,000 years. The women who did have real, practical knowledge of female health, the midwives, the herbalists, the healers who had built up generations of understanding through direct experience with pregnancy, childbirth, monthly cycles, and the conditions that shaped women's lives, were not just excluded from the medical system. They were hunted by it. Their knowledge was a threat. Their results exposed how empty the theories of university-trained physicians really were. They were competition. And the male medical establishment had one weapon no female healer could fight: the institutional power of the church, which could turn a woman who healed with herbs into a woman who cursed with potions with nothing more than a single accusation. But that persecution comes later. First, the treatments, because the treatments are where theory met the body, where abstract ideas about cold and wet and wandering organs became smoke and blood and screaming in a stone room. And it all began with the most intimate violation the medical system could design. The wandering organ theory was a cornerstone of everything. Every diagnosis, every treatment, every intervention performed on a woman's body for over 1,000 years was tied, directly or indirectly, to the belief that the organ responsible for carrying children moved freely through the body like a creature with its own will and its own desires. Hippocrates described it first, in the 5th century before the Common Era. He wrote that this organ was an animal living inside a larger animal, capable of moving on its own, driven by urges a woman herself could not control, and that the physician must manage on her behalf. When it moved upward and pressed against the lungs and throat, it caused breathlessness, fainting, anxiety, irrational behavior, uncontrollable crying, the full collection of symptoms the Greeks grouped under the word hysteria. When it moved downward, it caused heaviness in the lower body, tiredness, difficulty walking, and failure to conceive. When it shifted sideways, it caused pain that could be mistaken for kidney or intestinal disease. Every symptom a woman could possibly have, from a headache to heartbreak, could be explained by the position of this one organ. The theory was a skeleton key that unlocked every diagnosis, and therefore never had to be questioned. Why does she weep? The organ has moved. Why does she refuse to eat? The organ has moved. Why does she resist her husband's authority? The organ has moved. The answer was always the same. Only the direction changed. Galen took this theory and built on it with the confidence of man who had never met a fact that challenged him. He added the humoral layer. The organ moved because the female body accumulated excess cold and wet humors it could not process on its own. The organ was searching for warmth, searching for moisture, responding to practice for centuries across every country in Europe on women whose bodies were run through a system of belief so completely wrong that every single treatment it created caused harm, and not one treatment it created provided any benefit at all. The men doing this were not monsters. They were trained professionals, educated at the finest institutions their world had to offer, working from textbooks approved by the church, the universities, and every authority that medieval society respected. They believed they were healing. The women strapped to those tables knew the truth. But the women on the tables were not the ones writing the books. Now, before I show you what happened to Margaret on that table, before I walk you through the full record of what medieval medicine did to women's bodies in the name of care, I need to take you back further. I need to show you how an entire civilization built a medical system around ideas about women's bodies that were not just wrong, but designed from the very beginning to treat being female as a disease that needed to be managed, because what happened in that stone room was not a mistake. It was a perfectly logical result of over 1,000 years of medical theory built on one simple belief, that women's bodies were broken, and that the men who studied those bodies, without ever truly understanding them, had the authority to fix what was never broken in the first place. Now, you might think medieval medicine was just primitive, that physicians back then were doing their honest best with limited tools, before microscopes, anatomy, and the scientific method. And for men's medicine, that is partially true. Medieval doctors treated broken bones, fevers, battlefield wounds. The methods were rough, but they were rooted in observation. They set fractures. They cauterized wounds. They learned through trial and error. It was crude, but it touched reality. For women, it touched something else entirely. For women, the medicine was built on a set of beliefs about the female body that were not just inaccurate. They were actively hostile. Beliefs that said women's bodies were defective versions of men's bodies. That being female was itself a kind of medical condition, a permanent disorder that needed constant management by male authorities who understood women's bodies better than the women living inside them. The foundation of all of this was one man, Galen, a Greek physician from the 2nd century whose theories controlled European medical thinking for over 1,000 years. Galen organized everything, the entire human body, all of nature, around 4 humors: blood, phlegm, yellow bile, and black bile. Health meant these 4 were balanced. Illness meant they were not. So far, this applied equally to men and women. But then Galen added something, a distinction that would shape the suffering of women for a millennium. Men, he said, were hot and dry. Women were cold and wet. This was not a small or neutral difference. In Galen's framework, hot and dry meant active, strong, rational, complete. Cold and wet meant passive, weak, emotional, and incomplete. The female body was not just different from the male body. It was defined as an inferior version of it, one that lacked a vital internal heat that would have made a whole. Every medical treatment ever designed for women in this era started from that premise. The female body was inherently disordered. Its coldness caused it to collect things that a man's heat would simply burn away. Its wetness made it unstable, unpredictable. Its fundamental incompleteness meant it needed outside management just to function at a basic level. A physician treating a man was correcting a temporary problem in an otherwise healthy system. A physician treating a woman was managing a permanent flaw built into her nature from birth. If you want to understand the full weight of what this framework produced, the treatments it justified, the suffering it caused, the centuries of damage done to women's bodies by men who call themselves healers, then subscribe to this channel right now. Hit that subscribe button, because what I am about to reveal did not stay in the medieval past. These assumptions carried forward, and where you are watching from right now, whether it's London or Lahore, New York, or Nairobi, this history touched every corner of the world that Galen's contribution turned the wandering organ from a mystery into something manageable. If the organ moved toward warmth, provide warmth where you wanted to go. If it was repelled by certain smells, use those smells to push it away from where you do not want it. The logic held together perfectly on paper. It was also completely wrong. Medieval physicians inherited both theories without changing a single word. The texts of Hippocrates and Galen were copied and recopied across centuries in monasteries and universities, gathering layer after layer of commentary that added to the original theories but never once questioned them. Each generation of physicians learned from the generation before that. The organ moved. Each generation treated women on that basis, and each generation saw results that seemed to confirm the belief. Because the treatments were painful enough to force dramatic reactions from the body, and physicians read every one of those reactions as proof that the organ was responding. A woman who screamed during fumigation, that was the organ resisting. A woman who fainted during manipulation, that was the organ settling back into place. A woman who vomited after being given purgatives, that was the corrupt humors being expelled. Every response the woman's body produced was filtered through the theory. And because the theory could explain everything, nothing could disprove it. This went on for over 1,000 years. It did not end because someone proved it wrong. It ended because a scientific revolution brought methods of investigation that made the old theories impossible to defend. When anatomists finally began systematically dissecting the female body, they found that the organ was fixed, held in place by ligaments and connective tissue. It did not move. It had never moved. The entire structure of medieval women's medicine, centuries of fumigation, manipulation, bleeding, and purging, had been built on a foundation that a single dissection could have collapsed. But that dissection had never been done, because the men in charge of medicine had never thought it necessary to check whether their theories matched reality. The text told them they were right. That was enough. Now, let's talk about the treatments themselves, because this is where the theory stopped being words on a page and started being something done to a woman's body. The primary treatment for the wandering organ was fumigation. The reasoning was straightforward within the theory's logic. If the organ had moved upward, drive it back down, apply foul smells at the nose to repel it, and pleasant smells at the lower body to attract it. If it had moved downward, reverse the process. The organ was treated like a creature with preferences. The physician's job was to use smell and smoke to herd it back where it belonged. The foul substances held under the woman's nose included burning sulfur, animal dung, burned feathers, burned human hair. These were held directly beneath her nostrils on a cloth or in a small brazier near her face. The smell was suffocating. Women gagged. They wept. They turned their heads and pulled against the straps holding them to the table. The physician saw this as confirmation that the treatment was working. The organ was responding. The more violent her reaction, the more certain he became that the organ was in motion. At the same time, pleasant substances were applied to her lower body. Myrrh, frankincense, sweet oils, aromatic resins, burned in a small vessel, with the smoke directed upward through a tube positioned between her legs. That tube was inserted into the most private passage of her body to make sure the fragrant smoke reached the organ directly. The smoke was hot. The tissue it contacted was among the most sensitive in the human body. The burns were immediate. The inflammation that followed was severe. An infection, in an era with no antiseptic practice, was common. The woman experienced what can only be described as being burned from the inside. Smoke and heat forced into internal tissue by a man who believed he was guiding a living creature back to its proper place. Medical texts compiled in 12th century Salerno, among the most widely copied manuscripts of the medieval period, describe fumigation procedures with a level of detail that confirms how routine this had become. Different substances were prescribed for different conditions. Sulfur for severe upward migration, burned wool for moderate cases, garlic smoke when excess humors were suspected. This was not occasional or experimental. This was standard, repeated, organized practice carried out across centuries on enormous numbers of women. The physical consequences were not difficult to trace. Burns that healed into scar tissue, chronic inflammation producing constant pain, infections that without any form of antibiotic treatment spread to surrounding organs and created new illness throughout the body, illness which the physician then treated with more fumigation, because the new symptoms were diagnosed as evidence that the organ was still moving. The treatment created the conditions for its own continuation. Each session caused damage. The damage created new symptoms. The new symptoms were read as proof of ongoing disorder. More fumigation was prescribed. This cycle could run for months, for years, each round compounding what the last one had done. Each round strengthening the physician's belief in the seriousness of the condition and the urgency of continued treatment. Some women endured fumigation dozens of times over the course of treatment that stretched across years. The cumulative damage was severe enough that even medieval medical texts occasionally noted complications from prolonged fumigation, though those complications were blamed on the stubbornness of the woman's condition, never on the treatment itself. The idea that the smoke was causing harm, rather than producing a cure, could not enter the diagnostic framework. The framework did not allow it. The treatment was correct. The text said so. If the woman was getting worse, the disease was getting worse. The answer was not less treatment. It was more. And when fumigation failed to resolve the woman's symptoms, and fumigation always failed, because the theory it was built on was wrong. When it failed, the physician moved to the next stage, manual manipulation. This was where the treatment shifted from smoke and smell to direct physical contact with the woman's body, performed by men whose entire understanding of what lay beneath the skin came from texts that had no connection to anatomical reality. It began with external manipulation. The physician placed both hands on the woman's abdomen and pressed downward, inward, attempting to feel the organ through the abdominal wall, and physically guided to where he believed it should be. He was pressing into a body he had never studied through dissection. He did not know what he was touching. The shapes beneath his hands could be the organ he was searching for, or the bladder, or the intestines, or any number of other structures that responded to forceful compression, not with healing movement, but with pain and internal damage. There was no way to tell the difference from the outside. And since the physician was not looking for distinctions, only for confirmation of what he already believed, every shape he felt confirmed his diagnosis, and every shift he produced confirmed his method. The force used was significant. Medieval texts instructed the practitioner to press firmly and to continue despite the patient's distress. Distress, which the text ATT, riveted to the organ resisting repositioning, not to the obvious reality of a man pressing hard into a woman's internal organs through the wall of her abdomen. Some texts describe a practitioner kneeling on the table beside the patient and using his body weight to increase the downward pressure. The results were extreme pain, internal bruising, compression of organs never meant to be compressed, and in some cases ruptured structures a physician did not even know existed because the texts had never described them. When external manipulation failed, some physicians moved inward, fingers or instruments inserted into the woman's most private passage to physically contact and reposition the organ from the inside. The Trotula text described these techniques with a clinical precision that points to regular practice, not rare intervention. The instruments used included smooth wooden rods, metal probes, and physicians' own fingers. None were sterilized. The concept did not exist. The tissue being contacted was fragile, sensitive, and vulnerable to tearing, which the instruments regularly caused. The infections that followed internal manipulation were among the deadliest complications of medieval women's medicine, producing fevers that could kill within days in an era where the link between unclean instruments and infection was centuries away from being understood. The woman on that table experienced this as exactly what it was. A man she may not have chosen to see, brought in by a husband who wanted her behavior corrected, inserting objects into the most intimate area of her body while she was strapped down, and her protests were treated as symptoms rather than objections. The physician heard a woman whose disordered body was resisting treatment. The woman felt something that no amount of medical language could disguise as care. The manipulation was repeated on a schedule prescribed by the text, weekly in some protocols, multiple times per week in severe cases. Each session opened wounds that had not healed from the last. Scar tissue built up, chronic pain developed, and was diagnosed as evidence that the organ remained unstable, requiring continued intervention. The same loop that had operated with fumigation operated identically here. Treatment caused damage. Damage produced symptoms. Symptoms justified more treatment. The woman's body deteriorated while the physician's confidence in his method stayed completely intact, because his framework had no room for the possibility that he was the cause of what he was treating. Then came bloodletting. Bloodletting was the universal treatment of medieval medicine. Every condition, every patient, every stage of illness could be addressed by opening a vein and draining blood until a physician decided enough corrupt humor had been removed. For men, it was painful and weakening, but at least loosely connected to practical observation. For women, it operated under an entirely different logic, a logic that transformed general treatment into something specifically targeted at the female body. The humoral framework held that women accumulated toxic blood their cold constitutions could not process. A man's natural internal heat burned away excess. Humor is the way fire burns away impurities. A woman's body lacked that heat. The blood accumulated. It thickened. It corrupted. And it needed to be removed artificially whenever the body's natural monthly cycle was insufficient to clear it. This meant that any disruption to a woman's monthly cycle, any irregularity, any absence, any reduction, was treated as a medical emergency. The body was failing to expel what it needed to expel. The physician had to do it for her. The veins selected for female bloodletting were chosen based on a theory of humoral correspondence, the belief that specific veins connected to specific organs, and that bleeding from the right vein would draw corrupt blood from the affected area. For women's conditions, the prescribed sites were the ankle, the inner thigh, and the saphenous vein at the knee, chosen for their perceived proximity to the organs of the lower body, believed to be the source of female illness. The woman was placed on a table or chair, her legs exposed. The physician or barber surgeon opened the vein with a lancet and collected the blood in a basin. The quantities removed were staggering by any modern measure. Texts prescribed bleeding the woman until she fainted, because unconsciousness was interpreted as confirmation that enough corrupt blood had been drained. A woman who remained conscious had not been bled enough. The treatment continued until the body gave out, until fainting, pallor, and loss of muscle control confirmed that the threshold had been crossed. For a woman already weakened by illness, malnutrition, or pregnancy, the blood loss could be fatal. For a woman who was healthy, it left her weakened for days or weeks, frequently followed by infection at the wound site. But the lancet was not the only tool. Leeches were the preferred instrument for more targeted blood. The locations where leeches were applied to women revealed just how completely medieval medicine treated the female body, not as a person to be healed, but as a landscape to be drained. Medical texts prescribed leeches to the inner thighs, the lower abdomen, and in documented cases to the most intimate and sensitive areas of the body, placed internally through the birth canal, to draw blood from the organs believed to be most directly affected by humoral imbalance. The leeches were inserted by the physician and left to feed until they detached on their own, engorged. The experience of the woman requires no elaboration. The text called it therapeutic. The woman experienced it as something for which therapeutic is not the word that comes to mind. Women who were bled repeatedly, and the text prescribed repeated bleeding for chronic conditions, on schedules as regular as any modern medication, developed the symptoms of chronic blood loss, fatigue, pallor, dizziness, inability to concentrate, weakness so severe that standing for extended periods became impossible. These symptoms were diagnosed as evidence of continued humoral imbalance requiring continued bleeding. The physician saw a woman whose corrupt blood was still accumulating despite treatment. What he was actually seeing was a woman whose physician was slowly draining her to death. The treatment produced the very symptoms it claimed to cure, and those symptoms justified the continuation of the treatment that produced them. Let me know in the comments whether you think any of these physicians ever questioned why their patients kept getting worse, because the answer explains everything about how a medical system built on false assumptions can survive for 1,000 years. The system did not need to work. It only needed the people running it to believe it was working. And since the people owning it were never the people on the table, belief was very easy to maintain. The medicines of medieval women's medicine read, like an inventory of poisons. The substances prescribed for women's conditions were not simply useless remedies that failed to help. They were toxic compounds that actively destroyed the bodies they were given to, producing symptoms that the physicians then treated with additional toxic compounds, in a cycle of poison that continued until the woman's organs gave out. Mercury was the cornerstone, prescribed for irregularities of a monthly cycle, for infertility, for skin conditions attributed to humoral imbalance, and for virtually any complaint the physician could connect, however loosely, to excess cold and wet humors. Mercury was given orally in liquid form, applied to the skin as a paste, and in some cases introduced directly into the body through the birth canal as a suppository meant to stimulate the organs into proper function. The effects of mercury on the human body were devastating, and they built over time. Tremors, tooth loss, hair loss, kidney failure, neurological damage that produced confusion, paranoia, and hallucinations. A woman treated with mercury over weeks or months developed symptoms that her physicians attributed to the worsening of her original condition. The mercury was making her sick. The sickness was treated with more mercury. The loop tightened with every dose. Lead compounds were prescribed with similar confidence, applied to the skin for conditions attributed to humoral discoloration, ingested in preparations meant to cool the body during fever. Lead poisoning produced abdominal pain, fatigue, cognitive impairment, and reproductive damage severe enough to cause miscarriage in pregnant women being treated for conditions entirely unrelated to their pregnancy. The physicians who prescribed lead did not understand its toxicity. The concept of cumulative chemical poisoning was centuries from being articulated. They saw a substance that produced visible effects on the body and read those effects as therapeutic rather than destructive. Arsenic appeared in infertility treatments. Small doses prescribed to stimulate the organs responsible for conception. The theory held that arsenic's heating properties could counteract the excessive coldness that the humoral framework identified as the root of infertility. The doses were small enough that acute poisoning was uncommon. Chronic poisoning from repeated administration was not uncommon at all. A woman taking arsenic preparations over months developed a gradual onset of weakness, skin lesions, and digestive disturbance, all of which the physician attributed to her worsening condition rather than to the substance he was putting into her body. Hellebore was a purgative of choice for severe cases, a plant so toxic that modern herbalists handle it with gloves. Medieval physicians prescribed it to induce violent vomiting and complete evacuation of the bowels, a process called purging, intended to expel the corrupt humors accumulated in the woman's cold and wet body. The doses prescribed in medical texts produced effects that went far beyond discomfort. Uncontrollable vomiting lasting hours. Diarrhea severe enough to cause dangerous dehydration. Cardiac irregularities from the plant's toxic compounds. And in cases where the dose was miscalculated or the woman's body was too weakened by previous treatments to survive, death. The text acknowledged that hellebore was dangerous. They prescribed it anyway because the theory demanded it. A woman full of corrupt humors needed to be emptied. Hellebore emptied her. That the emptying might kill her was a risk the physician was willing to take, because the risk was not his to bear. Pennyroyal completed the assault, an herb prescribed specifically to force the return of the monthly cycle in women whose cycles had stopped or become irregular. Pennyroyal is toxic to the liver. In the doses medieval texts prescribed, it produced liver damage that showed up as jaundice, abdominal swelling, and pain, all of which physicians diagnosed as evidence of continued humoral disorder. Women who survived pennyroyal treatment carried liver damage that shortened their lives by years or decades. Women who did not survive were recorded in medical texts as cases where the disease proved stronger than the remedy. The possibility that the remedy was the disease did not occur to the men writing those texts, because the texts had been written by men who had never been on the table. When smoke and hands and poison all failed, the medieval physician reached for the knife. Surgical intervention on women's bodies, performed by men with no accurate anatomical knowledge, no effective pain management, and no understanding. The stone room where Margaret lay strapped to the table had a second set of instruments, kept for cases where the earlier treatments had not produced the desired result. Metal tools forged by blacksmiths, not surgical instrument makers. Blades that were sharpened but never sterilized. Cauterizing irons heated in the same fire that had warmed the fumigation pot. The progression from fumigation to manipulation to bleeding to surgery was the standard pipeline of medieval women's medicine, each stage more invasive than the last. Each stage justified by the failure of the one before it, and every failure blamed not on the treatment, but on the severity of the woman's condition. Cauterization was the most common surgical intervention applied to women's bodies. Heated metal press against the most sensitive tissue of the lower body to treat conditions ranging from abnormal bleeding to prolapse to pain that the physician attributed to the wandering organ's stubborn refusal to stay in place. The iron was heated until it glowed. The woman was restrained, and then it was pressed against tissue so densely packed with nerve endings that the pain produced was among the most extreme the human body can experience. The woman screamed. The assistants held her down. The physician applied the iron for the duration the text prescribed. Not the duration the woman's body signal was enough, because the text had established a protocol, and the screaming was classified as a symptom rather than a signal to stop. The burns were severe. Third-degree burns on tissue that heals slowly under the best conditions, and that in medieval conditions, without sterile dressings, without any form of infection control, frequently became infected. The infection spread. Fever followed. The fever was treated with bloodletting. The bloodletting weakened the woman further. The weakness slowed healing. The slow healing extended the infection. Each treatment compounding the damage of the one before it in a cascade that could continue for weeks, until the woman either recovered through the sheer resilience of her own body despite everything done to it, or died of complications that the physician recorded as the natural progression of an illness too severe for medicine to overcome. Cesarean procedures on living women were rare, but documented. The operation involved cutting through the abdominal wall to remove an infant that could not be delivered naturally. The mortality rate for the mother approached 100%. There was no understanding of how to control bleeding from the incisions, no understanding of infection, no ability to repair what had been cut open. The procedure was performed almost exclusively when the mother was already expected to die, and its primary purpose was not to save her life. It was to reach the infant in time for baptism before it died with her. The mother's survival was not the objective. Her body was open to access what was inside it. She was a container being broken to reach its contents. The surgical text describing the procedure focused almost entirely on the technique for extracting the infant. The mother's pain, her terror, her death, these received no more attention than the wooden table she lay on. Repairs after childbirth injuries were performed with the same instruments and the same ignorance. Tearing during delivery was common. Repairs involved cutting away damaged tissue and suturing the wound closed with thread and needle by practitioners who had no knowledge of sterile technique. The sutures introduced infection. The infection produced fever, swelling, and pain that made basic bodily functions an ordeal. Some repairs healed badly enough that the woman was left with permanent damage, affecting her ability to walk, to sit, to carry out the daily tasks her household demanded of her. The injury from childbirth was compounded by the injury from its treatment, and both were classified by the medical system as a natural cause of being female. The body was defective. It broke. The physician did what he could. If the repair caused as much damage as the injury, that was the body's fault, not his. The cruelest intersection of medieval medicine and women's bodies came around fertility and pregnancy. The stakes were highest here. A woman who could not conceive faced consequences ranging from social shame to abandonment to confinement in a religious institution. A woman who was pregnant faced medical interventions that endangered both her life and the life she was carrying. In both cases, the treatments were governed by the same framework of ignorance that had produced fumigation and cauterization, now applied to the domain where being wrong carried the heaviest possible cost. Infertility was always attributed to the woman. Always. The medical texts of the medieval period contained no diagnostic framework for male infertility whatsoever. The possibility that a man's body might be the reason a couple could not conceive did not exist within the humoral system, because the male body was hot and dry and therefore functional by definition. If conception did not occur, the woman's cold and wet constitution was obstructing it. Her body was blocking what his body was providing. The diagnosis was automatic. The burden of treatment fell entirely on her. The diagnostic tests for female fertility were humiliating and medically worthless. The most widely prescribed involved inserting a clove of garlic into the woman's most private passage and leaving it overnight. In the morning, the physician checked whether the smell of garlic could be detected on her breath. If it could, the reproductive passage was declared open and conception was theoretically possible. If it could not, the passage was declared blocked and the physician moved to interventions designed to force it open. The test measured nothing. It diagnosed nothing. It subjected a woman to an invasive and degrading procedure that produced a result interpreted through a framework with no connection to reproductive biology whatsoever. And yet it was prescribed in the most authoritative medical texts of the era. It was standard practice across Europe for centuries, and it was only the beginning. Women diagnosed as blocked underwent treatments designed to force the passage open. Fumigation with increasingly aggressive substances. Internal manipulation with instruments intended to physically clear whatever physician believed was causing the obstruction. Purgatives administered to expel the corrupt humors supposedly responsible for blockage. Every round of treatment damaged the tissue it contacted, and every round of damage reduced a woman's actual ability to conceive, scarring and inflaming the very structures that reproduction required to function. The treatments for infertility were causing infertility. The physicians never made the connection because the framework did not allow it. Pregnancy was no safer. Physicians prescribed bloodletting during pregnancy based on a humoral theory that pregnant women accumulated excess blood that needed to be drained to prevent complications. The bleeding weakened women whose bodies were already under enormous strain. It produced the exact complications it was meant to prevent: dizziness, fainting, weakness, heightened vulnerability to illness. Purgatives were prescribed to stop corrupt humors from building up during pregnancy. The violent vomiting and evacuation they caused created dangerous dehydration and nutritional loss in women who needed fluids and nourishment more urgently than at any other point in their lives. Some purgatives were toxic enough to end the pregnancy entirely, an outcome the physician attributed to severity of the woman's humoral disorder rather than to the poison he had put into her body. Childbirth itself was paradoxically safer when physicians stayed away. Midwives who managed deliveries through practical experience and accumulated generational knowledge consistently achieved better outcomes than physician intervention produced. Midwives understood through centuries of direct observation how the process worked. They knew when to act and when to wait. They knew which positions eased delivery. They knew which herbs genuinely helped with pain. When physicians intervened in difficult births, they brought instruments, theories, and an absolute confidence in their own authority, and they consistently made things worse. The women least served by medieval medicine were the ones whose conditions most urgently required competent care. And competent care existed. It simply existed in the hands of women the medical establishment was actively working to destroy. Drop a comment on what it means when the people who actually knew how to help were the ones being silenced, because the next part tells you exactly what happened to them. When the treatments failed, and they always failed, because they were built on theories with no connection to the bodies they were applied to, the physician faced a problem he could not ignore. The woman was not better. She might be worse. The fumigation had not resolved her symptoms. The manipulation had not resolved them. The bleeding had not resolved them. The potions had not resolved them. He had used every tool available to him, and the woman on the table was still weeping, still refusing food, still displaying the behaviors that her husband had brought her here to have corrected. The physician needed an explanation that preserved the authority of his methods while accounting for their failure. He found it in the same institution that had authorized his practice in the first place, the church. The transition was seamless. A woman whose condition resisted medical treatment was simply reclassified. Her disorder was no longer physical. It was spiritual. The wandering organ had been replaced by a wandering demon. The language changed. The diagnosis changed. The authority over her body shifted from the physician to the clergy. But the woman's experience did not change. She remained on the table. The straps remained tight. The only thing that changed was the explanation for why she was there. Spiritual diagnosis opened a new category of treatment: exorcism, confinement, penance, prayer administered not as comfort, but as prescription, recited over the woman's body while she was restrained, repeated for hours or days until the spiritual affliction was considered expelled. The rituals varied by region and by religious order, but the physical elements were consistent. The woman was held down. Holy water was poured over her. Prayers were shouted at a volume intended to drive the demon out through sheer spiritual force. In some documented cases, the woman was struck during exorcism. The blows were not meant as punishment. They were meant to make her body an unwelcoming environment for the entity believed to inhabit it. The logic was identical to fumigation. Apply something unpleasant to drive the unwanted occupant out. The smoke had been replaced by scripture. The result for the woman was the same. When exorcism failed, confinement followed. Women whose symptoms persisted after both medical and spiritual treatment were placed in religious institutions, convents, monasteries with attached women's quarters, or dedicated houses of confinement maintained by religious orders. The duration was open-ended. Some women were held for weeks, some for months, some for the remainder of their lives. Conditions varied enormously. Well-funded institutions provided austere but survivable circumstances. Plain food, prayer schedules, manual labor, limited contact with the outside world. Poorly maintained institutions provided something much closer to imprisonment. Women chained to walls or beds to prevent them from harming themselves or others, a precaution applied liberally to any woman whose spiritual affliction manifested as resistance to being confined. Women starved through purification rituals designed to weaken the body, so the spirit could be more easily cleansed. Women submerged in cold water. The shock intended to drive out demonic presence the way a sudden noise drives out a rat. The woman who had entered the system with symptoms that any modern physician would recognize as depression, anxiety, grief, or the entirely natural response of a human being to a life she had not chosen and could not escape. That woman emerged from the institutional system broken. The original symptoms, the weeping and the refusal to eat and the resistance her husband had found intolerable, had been buried beneath layers of medical injury, spiritual trauma, and the psychological devastation of months or years spent confined in a stone room, being told that the pain she felt was evidence of evil living inside her. The system had not treated her illness. It had treated her identity. It had taken a woman who was suffering and classified that suffering as defect, first physical, then spiritual, and it had applied treatments designed not to relieve the suffering, but to eliminate the woman who expressed it. What emerged from the confinement was not a healed person. It was a silenced one, and silence was the only outcome this system had ever been designed to produce. The women who actually knew how to help other women were the ones the system destroyed most thoroughly. The midwives, the herbalists, the village, the healers, women who had accumulated generations of practical knowledge about the female body through direct experience, wisdom passed from mother to daughter across centuries. They understood pregnancy because they had witnessed hundreds of births. They understood monthly cycles because they had lived through them. They knew which herbs ease pain, which plants reduce fever, which preparations carried a woman to the most dangerous hours of her life. Their knowledge was built on observation, on watching what actually happened to actual bodies, and in many cases it was more effective than anything the university-trained physicians offered, because it was rooted in reality rather than in what a Greek philosopher had speculated 1,000 years earlier. The male medical establishment saw these women as a threat, not because their methods were dangerous, because their methods worked. A midwife who successfully managed a difficult birth exposed the inadequacy of a physician who would have reached for instruments and theories and produced a worse outcome. A herbalist who relieved pain with willow bark and chamomile undermined the authority of a physician whose pharmacology consisted of mercury and hellebore. These women were competitors operating entirely outside the institutional framework that gave male physicians their power. And that framework had a mechanism for eliminating competition that no herbalist or midwife could defend against. The church provided the weapon. Female healing had always existed in uneasy relationship with church doctrine. A woman who used herbs to treat illness occupied a space that theology could classify as either medicine or sorcery, depending entirely on who was doing the classifying. The same preparation of plants that one observer called a remedy, another could call a potion. The same hands one community trusted to deliver a baby, another authority could accuse of practicing dark arts. The boundary between healing and witchcraft was not defined by what the woman did. It was defined by who was describing what she did. And by the 15th century, the people doing the describing had made their decision. Female healing was demonic. The Malleus Maleficarum, published in 1487 by the Dominican friar Heinrich Kramer, made the connection explicit. This text, which became the most influential handbook on witchcraft in European history, specifically identified midwives as among the most dangerous practitioners of dark arts. Women who assisted in childbirth were accused of secretly harming infants. Women who used herbs were accused of brewing poisons and casting curses. Women who essayed knowledge of the female body that male physicians did not possess were accused of having obtained that knowledge through communion with demonic forces, because no natural explanation could account for a woman knowing more than a man trained at a university. The persecution that followed was systematic, and it was devastating. Across the 15th, 16th, and 17th centuries, thousands of women who practiced healing were accused, tried, and executed for witchcraft. The exact numbers are debated by historians. The pattern is not. Women who healed were disproportionately targeted. Women who possessed knowledge of herbs and remedies were disproportionately accused. The trials did not just eliminate individual women. They eliminated entire traditions of knowledge. When a village healer was burned, her knowledge burned with her. When a midwife was executed, the generations of practical wisdom she carried, knowledge that existed in no written form, only in her memory and her hands, was destroyed permanently. The male medical establishment filled the void. Physicians who had never attended a birth took authority over childbirth. Men who had never experienced a monthly cycle took authority over its treatment. The practical knowledge female healers had spent centuries building was replaced by the theoretical knowledge male physicians carried in their texts, and the outcomes for women deteriorated in ways that can be measured. Maternal mortality in areas where midwives were suppressed and physicians took over increased. The women who had been burned as witches had been keeping other women alive. Their removal killed more women than the fires ever did. Now, let me take you back to the stone room beneath the monastery, back to Margaret, 24 years old, strapped to a wooden table, staring at a damp ceiling, while a man who has never examined a woman's body prepares to treat hers, using theories written by men who never examined one either. Her husband brought her here because she wept, because she refused to eat, because she resisted his authority in the household. Modern medicine has a clear vocabulary for what Margaret was experiencing. Depression, perhaps. Grief, perhaps. Or simply the psychological response of a woman living inside a marriage she did not choose, in a household she could not leave, in a society that classified her unhappiness as illness and her resistance as disorder. Margaret was not sick. Margaret was trapped, and the system she had been delivered into was designed not to free her, but to make her stop showing signs of wanting to be free. The fumigation came first. Sulfur held beneath her nose. Smoke directed into her lower body through a tube. The burning that followed lasted hours after the procedure ended. The inflammation that developed over following days made standing painful and sitting worse. She was brought back the following week. The physician noted that her symptoms had not improved. She was still weeping. She had eaten less since the first treatment, not more. He interpreted this as evidence that the organ had not yet returned to its proper position. He prescribed a second fumigation with stronger substances. The manipulation came after the third fumigation. Both hands pressed hard onto her abdomen, pushing downward with force that bruised her internally. The physician felt resistance beneath his palms and interpreted it as the organ refusing to settle. He pressed harder. Margaret screamed. The assistant held her shoulders. The physician continued. because the text instructed him to persist despite the patient's distress. The distress was the organ resisting. More force was required. The bleeding came next. Leeches applied to her inner thighs and lower abdomen. The blood they drew was collected and examined for color and consistency, both of which confirmed to physician's satisfaction the presence of corrupt humors in quantities that explained the severity of her condition. She was bled weekly for a month. By the end of that month, she could not stand without assistance. Her skin was pale. Her hands trembled. She had stopped weeping, which the physician recorded as improvement. She had not stopped weeping because she felt better. She had stopped because she no longer had the energy to cry. The potions followed. Mercury preparations given orally. The tremors in her hands grew worse. Her teeth loosened. Her hair began to fall out. The physician recorded these as signs that the corrupt humors were being expelled to the body surfaces. The treatment was working. He increased the dose. When the mercury failed to restore her obedience to her husband's satisfaction, the physician made a referral that the system had always been designed to produce. Margaret's condition was no longer medical. It was spiritual. She was handed over to the monastery's clergy. The exorcism lasted 3 days. The confinement that followed lasted 4 months. What emerged from that confinement was not the woman who had entered the stone room weeping and refusing to eat. What emerged was someone who had learned that the cost of expressing suffering was greater than the cost of enduring it in silence. The system had achieved its objective. Not healing, silence. Margaret's husband collected her on a Tuesday morning. He reported to the monks that she seemed improved. She did not weep. She did not refuse food. She did not resist. He thanked the physician, paid the fee, and took his wife home. The physician recorded the case as a success. The treatment had worked. The woman was cured. The wandering organ theory was not abandoned until the modern era. The word hysteria, taken directly from the Greek name for the organ that was supposed to wander, remained a recognized medical diagnosis in Western medicine well into the 20th century. The American Psychiatric Association did not remove it from its diagnostic manual until 1980. 1980. The theory that had strapped Margaret to a table in 1312 was still being used to classify women's symptoms 668 years later. The name had changed. The treatments had softened. But the core assumption that women's distress originated in their reproductive biology rather than in their lived experience persisted with a stubbornness that centuries of anatomical evidence could not fully remove. And the legacy did not stop there. Medical researchers in the 21st century have documented a measurable, consistent gap between how men's pain and women's pain are treated in clinical settings. Women reporting identical symptoms to men wait longer for treatment. They receive less pain medication. They are more likely to have their symptoms attributed to anxiety or emotional disturbance rather than to physical causes. Studies published in peer-reviewed journals have traced this disparity directly back to the medieval framework that classified female suff. Fearing is inherently less credible than male suffering, because the female body was understood as inherently less stable. The physicians who treated Margaret believed that women's bodies were disordered by nature. The physicians who treat women today do not consciously hold that belief, but the system they inherited was built by people who did. And systems carry assumptions long after the people inside them have forgotten where those assumptions came from. The women who endured medieval medicine left no accounts of their own treatment. They survive only as case descriptions in texts written by the men who treated them. The physician's perspective is the only perspective that was ever recorded. He documented what he did. He documented what he observed. He did not document what the woman felt, because her experience was not considered medically relevant. The gap between what the physician believed he was doing and what the woman experienced on that table is a gap that medical history has only recently begun to honestly face. For the physicians, these were treatments. For the women, there was no meaningful difference between treatment and harm. Both were administered by the same hands, in the same rooms, with the same instruments. Both were endured by women who could not refuse, could not leave, and could not describe what was happening to them in any language the system would accept as valid. Margaret is not in any archive. Her name is drawn from fragments of case records scattered across medieval medical manuscripts. But the fragments are consistent enough to confirm that her experience was standard. The fumigation, the manipulation, the bleeding, the potions, the shift from medical to spiritual diagnosis, the confinement, and the silence the system produced and called a cure. Thousands of women across centuries of European history were processed through the same pipeline. Each one entered the system because a man decided she was disordered. Each one was treated by men who did not understand her body. Each one emerged either silenced or destroyed. And each one was recorded as a case study in the texts that trained the next generation of physicians to do the same thing to the next generation of women. If what you have learned today matters to you, subscribe to this channel right now. Hit that subscribe button and turn on the notification bell. Because the history buried inside the language of medicine is the history that most directly shapes how women are treated today. Share this video with anyone who has ever been told that her pain was in her head, because that sentence has a 1,000-year history. And it began in a stone room with a fumigation pot and a man who believed a textbook more than he believed the woman screaming on his table. Now drop a comment and tell me, which part of this history disturbed you the most? And tell me where in the world you are watching from, because this story belongs to every woman who has ever been disbelieved by a system that was built from the very beginning to disbelieve her. Medieval Europe was not the only civilization that built a medical system designed to control women's bodies rather than heal them. There is another chapter from another era where the methods were different but the purpose was identical. That story is waiting for you right now. Click the video on your screen and keep watching.